some advices for Viva exam tomorrow.
Mm.
Please, please, please. This is exam of nerves. Okay, so be calm. Whatever
Mm.
happens, you may face any changes, any technical problem. Don't worry. All of us faced it before. Okay. If any breakdown happened, please stop or talk to the people around you. Ask for IT persons to come to fix it. Tell the examiner frankly and practically, all of them are on your side, even the examiner. Most of the examiner know this is a very difficult and stressful situation, really. So, really, really, many of them are يعني, have a smile face, helping you because it is not an easy exam. They know. So all the navigator, everybody there in the committee, in the exam, will help you. Second point, if you presented with a difficult case, be calm. Really, be calm. Start, have a look, and start to describe. When you are describing, there are intellectual process inside your brain start to work, and then everything become more obvious than before. Okay, it is like a step ladder. So don't be afraid at the beginning that you either what is this? I don't know the diagnosis. What? No problem. Take it step by step. Even if you did one case not well, don't worry. Many people start, especially at the beginning. Most of us didn't start well. I remember last January, my Viva, the examiner first case was very easy. However, I was struggling. It was very easy. Why? Because it is very stressful exam. But once you pass first case, you will be calm. You will go through. Everything will be okay. And be sure all of us go in the same pathway. Not you. You are all of you did great effort along the last many few months. God will help you, sure, sure, because most of you did your best. So stay calm, and hopefully you will pass. Let's start with our first candidate.
Yes.
Okay, okay. 15-year-old, sorry, oh, 15-year-old female patient presented with pain and swelling around the knee. Would you request control, please, our lead doctor?
Yes, sir. Yes.
Okay.
Mm.
Yes, go on.
Able to scroll,
1 second.
but
Sure.
uh, but the history actually different patient is another
Le-
clinical presentation is shown.
One
Ignore that.
second.
Yes.
One second.
Uh,
Scroll.
I'm not able to scroll.
1 second. Leave the mouse. Leave. Use the arrows.
Okay. Arrows also not working, sir.
Okay, we'll scroll for you. Go on. Go on.
I'm not able to see that.
But I'm scrolling for you.
I'm not
What do
able
you
to
see?
see that.
My screen is obvious or not?
I can see,
No,
but
sir.
that's
Sir,
another
can you
station.
yeah.
We see static image only. Axial pelvic image, not moving.
And there also another clinical presentation is 27 days old. Male patient is written.
Okay. Again. Let's start again. Could you see my
Oh,
screen?
yes, yes. Now
Okay,
we can see.
let's start. 1 second. Good evening, my colleagues. Let's start our first pediatric Viva session today. This is a 15-year-old female patient presented with pain and swelling around the knee. Could you request control, please, doctor?
Yes, yes, sir. Yes, sir. They requested for control. Yes, I can. Okay. This is the MRI scan, T1 weighted images of a 15-year-old child with a knee pain and swelling.
Okay.
There is evidence of a hypoindense lesion involving the lower aspect of the right femur with
Okay.
the evidence of soft tissue component adjacent to the lesion. And
Okay.
there is lesion is extending up to the articular surface and into the joint space. The soft tissue is knotted, and there is no evidence of extension of the lesion into the tibia. And uh, uh, there is I would like to see the other images also to see the full extent of the lesion, whether there is any skip lesion or no. This one, actually, this is an aggressive looking in the present sequence. It is looking an aggressive lesion because of the soft tissue component and cortical break.
Excellent.
So I'm suspecting osteosarcoma in this case, depending upon the age of the patient, as 15 years. That's my first diagnosis. Other differential can be other malignant lesions like lymphoma, etc., which is less likely. I would also like to correlate with the radiograph of the patient to see for other other
Okay,
findings like
this is post contrast, doctor.
okay, post contrast images of the same case shows evidence of contrast enhancement, significant contrast enhancement of the lesion, including the soft tissue component. And uh, okay, this is all suggestive of malignant etiology like osteosarcoma. And I would like to see the below the I can see the joint above as well to see for any skip lesion also, which
Excellent.
is very prone in this case.
Excellent.
And
See, see, doctor. Doctor, what is this?
it's a periosteal reaction.
More than
It's a,
excellent. Okay.
what's a, uh,
Could,
so
could you what could you show
what's
me the or could you tell me what is the name or of this
sunburst
pedestrian
type of
reaction? Okay.
periosteal reaction. Mm.
Okay. What is this exactly? This one.
That is, it's a cortical bone. There's a elevated periosteum.
Excellent. What
Mm.
is this?
It is a this sunburst type of reaction.
More than excellent, doctor. Okay. Yeah.
Yes. Next step. Okay. So I will inform the findings of the referring physician and refer the patient to the sarcoma specific center for biopsy of the lesion. And this patient needs a staging CT scan of the chest, abdomen, and pelvis.
Excellent.
And also, I will
And
discuss the case in a oncology multidisciplinary team regarding the
and
further.
and something else besides the CT staging, CT, you told the CT
Bone
scan.
scan also, and
Yes.
or CT scan,
Ah,
chest abdominals, and bone scan also to look for any metastasis.
no. Only CT chest. Why? Because
It can
osteosarcoma.
cause
Ah,
prone for
not
pneumothorax
yeah,
metastasis.
excellent. Not common to cause any metastasis in the bone, mainly in the chest. Okay,
Chest only. Mm.
excellent, doctor. More than excellent. Really, really hallmark. Thank you, doctor, so much.
Thank you.
Doctor, could you enumerate some types of osteosarcoma?
Could you, sir?
Enumerate types
Ah,
of osteosarcoma, please.
can be central osteosarcoma, parosteal osteosarcoma,
Excellent.
periosteal, telangiectatic,
Excellent.
and narthetic
Excellent.
osteosarcoma.
Thank you, doctor, so much. If you keep calm tomorrow, I think you will pass very easily. Thank you so much, doctor.
Okay.
Thank you, really, really, thank you. See, by
Mm.
the way, this is the CT of this patient. Uh, one second. This is the CT. See my colleagues. Just the CT, just some soft tissue thickening here and the periosteal action or calcification. See the one window. Thank you, doctor. You did very, very well. It is a case of conventional osteosarcoma. You did very well when you told me that you will do an image for whole the limb because it is maybe multicentric. The most important question here, and you answer it completely. And by the way, expect that one of the examiner will do this. He will bring the exam like this, and he will ask, "What is this?" Or he will ask you, "Doctor, could you show me the periosteum?" This one, periosteal itself. Could you show me the periosteal action? This one. Why? Because the osteoid tissue is low signal or signal void. The periosteal is a fibrous membrane, so it must be a low signal or signal void. Thank you, doctor, so much. I'm so impressed. Next candidate.
Yeah. Good evening, sir. Candidate 2 here.
Yes, good
Sir,
evening.
I'm just one request is there. I'm outside with tablets, so sir, I
No
request you to
problem, no
please
problem.
scroll for me. Yeah.
No
Thank you,
problem,
sir.
no problem.
Okay. Okay.
Year-old
Sir,
male
sir.
patient
Okay.
presented
Okay.
with leukorrhea.
Okay. So, okay, I have been provided with uh, T2 weighted images of the axial sections of the brain, MRI, including orbit. And I am first, with this history, I'm focusing on the orbit.
Yes,
Uh, in the or in yeah in in the left eye, I notice a triangular area of hyperdensity, which is left side. There is a triangular area of opacity, which is connecting up to the no, and actually the hyperdense areas are noted in the globe on both sides. Can you sir scroll it?
yes.
Uh,
Doctor, you didn't tell
yeah.
me the type of the sequence.
Yes, sir.
What
I
is
told it's T2 weighted Excel.
sure? Is this T2? Look again, please.
Okay, so sorry, sir. Yeah, it's T1 weighted. T1
Yes,
weighted.
with
Yes.
or without contrast.
Yeah, with contrast, sir.
Okay. What you
Mm,
see in the
yeah.
orbits here,
Okay. Yeah. Yeah.
in both
So
orbits.
in this T1 weighted contrast study, I noticed in the both globes there is a heterogeneous
Excellent,
increase area of enhancement. There is a bright signal on both globes
excellent.
in the posterior aspect
Okay,
along the uh, vitreous and along the retinal curve in the vitreous matter. So
okay.
these appear to be enhancing. However, I'll correlate with the plane images to see the enhancement. And if these are enhancing, this is concerning for retinal tumor like retinoblastoma. I
Excellent.
also want to, yeah, I would like to see the for any calcification in the area, which I don't, it's not evident in these images. Also, I
What
want to see
sequence?
the,
What
well, I
sequence?
also want to see
Yes,
SWI, sir.
excellent, excellent. Really, really
And I want to
excellent.
see the course of orbit, or the optic nerve, yeah, in the SWI focal areas of blooming are there, which probably appears to be calcification or or otherwise it could be because of bleed. If correlate with any CT if available for confirmation of the calcification, or by
So,
ultrasound also.
so
Yeah.
give me your
And
final diagnosis, please.
so with this bilateral posterior segment hyperintense enhancing lesions, I am thinking of bilateral retinoblastoma, and I
Excellent.
don't see any clear extension into the optic nerve. Optic nerves, the intracorneal part appears to be spared till now. I'm also concerned about the possibility of trilateral retinoblastoma, so I will focus on the pineal gland to see for
Okay.
any coexistent pineal tumor. Uh,
Could you find
yeah,
anything
there
in the
is
pioneer?
there is a enhancing focus is noted in the
Excellent.
midline at the level of pineal. So this is a pineal uh, pinealoblastoma, coexisting pinealoblastoma, but however it is homogeneous and small and enhancing. So this with these findings, it makes a spectrum of trilateral retinoblastoma with including pinealoblastoma.
Excellent, doctor.
Pineal
Thank you
tumor. Yeah.
so much. Thank you.
There's no apart from that there's no hydrocephalus in the
Excellent.
images, and there's no midline shift, no significant mass effect due to pineal tumor. However, I would
Excellent.
like to see in the sagittal images to see for any compression of the corpora quadrigemina for the concern of perinode syndrome.
Thank you, doctor, so much. Really,
Yeah.
really, I'm
Thank you.
so impressed.
Thank you, sir.
I trust all of
Thank
you,
you.
really, our great John candidate. See my colleagues,
Thank you, sir.
bilateral enhancing retinal masses. Okay. Second step, immediately after checking the both orbital, both optic nerve and the optic chiasm for any extension. Okay, for any extension. Second, to see the linear region. There are an enhancing lesion here. Okay, it is a big doubt here. Where is the linear region? Where? See here.
Yeah.
This is the brainstem. Anterior to it,
Yeah.
consider cella. Posterior to it,
Mm,
to
mm,
the
mm,
brainstem as a general, thinking
mm,
in a pioneer region.
mm,
Really, I'm not
mm,
sure if there are, yeah, okay, this is enhancing. So if
mm.
we have, if we have sagittal,
Yes.
sagittal, yes, we will be sure about the
Mm,
location. Anyway, at least you mentioned and you told the examiner that you are searching or you are afraid about trilateral retinoblastoma. Okay.
mm.
Second, you want to rule out or rule in the calcification. You did very
Yes.
well when you asked for SWI or gradient or
Mm,
or T2 star. This is a gradient.
mm,
Signal
mm.
loss here due to calcification. Thank you, doctor, so much.
Yeah. Yeah.
Next
Thank you, sir.
candidate. Next candidate.
Yes, sir.
Hello, Dr. Roshni.
Hello, sir.
Full mark, Dr. Roshni. I'm waiting from your. Okay.
Yes, sir.
Okay, Dr. Roshni. Okay. 50. See, I gave the joint candidate three typical exam cases. Completely typical. Okay, my colleagues. 15-year-old male patient presented with knee pain. He has a history of injury after rugby 1 year ago.
Okay. I have been provided with a frontal radiograph of an left knee joint of an skeletally immature patient who is presented with a complaint of knee pain. Looking at the radiograph, I can see that there is evidence of a lucent lesion with the sclerotic margin noted on the uh,
Excellent.
distal femoral epiphysis.
Excellent.
Um, it it seems to be it has a narrow zone of transition. There is no any evidence of cortical break or any soft tissue swelling. Um, um, And looking this, the other radiograph appears relatively normal to me. I could not find any evidence of joint fusion. Um,
What is your next step?
yes, so this is the differential for this is likely a chondroblastoma. The differential would be a
Excellent.
geocyst. I will correlate my finding with the further cross-section imaging, including the MRI of the knee, if available.
Yeah. Scroll, Dr. Roshni.
Yes, sir.
Okay.
Okay, so I have been provided with coronal MRI images of a knee joint. These are the fluid sensitivity images. Um, Here I can see there is a diffuse marrow edema noted within the distal femoral epiphysis. Also, there is a hypertension signals are also seen around the adjacent muscle. Um, I can see there is a hyperintense lesion. It is quite lobulated with a sclerotic, like a T2
Excellent.
hyperintense margin.
Excellent.
In the epiphyseal region, the edema signals are also seen on the left lateral aspect of the epiphysis. The growth plate appears to be a normal. There is no abnormal signal seen within the metaphysis of this of the femur. The tibia appears normal. So, in summary, there is a. I would like to see the post-contrast images if available, and
No contrast. Give me diagnosis, doctor, please.
so in summary, this is a the findings are likely in keeping with a chondroblastoma. Um,
Mm-hmm.
and The other differential for this geodes, which is less likely, and the so I will convey my findings to the referring physician, refer this patient to the pediatric orthopedic for further management. Um, yes.
What is the further management for chondroblastoma?
Chondroblastoma, these are usually like a benign, but they can undergo for surgical resection. Yes,
Okay. Thank you, doctor, so much. Why is this not a giant cell tumor?
because it is not an expensile, and it is not at a subarticular location, and there
What
are
else?
yes, the margins are sclerotic in this lesion, which is not present in the GCT.
But what else? According to the age of patient.
The epiphyses are not closed. Yeah.
Yeah. Okay. Thank you, Dr. Roshni. You did very well. This is a case to see my colleagues from the X-ray. There are lucent lesions surrounded by sclerosis. The lesion is of narrow zone of transition and has a sclerotic margin. So it is a benign looking or non-aggressive. Plus, the cortex is intact, no soft tissue, extraosseous, no periosteal reaction. We shift to the MRI, like the doctor said, because the benign criteria plus non-closure of epiphyseal plate, our chondroblastoma is on top of our differential diagnosis. Okay, my colleague, chondroblastoma. See, this is the chondroblastoma. Thank you, Dr. Roshni, so much.
Thank you, sir.
Do we have any John candidate or not?
Oh,
Candidate number
no,
4.
sir, I think I'm a October candidate.
Okay. So our candidate, we have
Yes, sir.
this week continuous till Thursday, continuous extensive course for all of you. Candidate 4.
Yes, sir.
Okay. This baby, this is just X-ray baby gram.
Okay, sir.
Okay. The
Sir,
baby is crying too much, irritable baby.
okay. Sir, I'm provided. Sir, can we zoom it a bit?
I think this is the maximum. This
Okay,
is the
I'm
maximum.
provided with the babygram of a child, and I could appreciate the endotracheal tube is in the position. I could also
Excellent.
appreciate NG tube with its tip lying in the stomach.
Mm.
Now, first I'm looking at the lungs. The lungs seem clear to me. I could appreciate that there is expansion of the rib at
Excellent.
bilaterally.
Excellent. Excellent.
In addition to that, I could appreciate that now I'm looking at the number of ribs. I think they are normal. I'm looking at the abdomen for any abnormality. Uh, I could see that there is a slight increase density in upper abdomen and bowel loops are displaced in the
Don't
center.
worry. See. Don't worry
Okay.
about the abdomen. No problem.
Okay. So I could appreciate abnormal periosteal reaction involving
Excellent.
the left femur.
Yes.
Similarly, I could appreciate. I think the right humerus also seem slightly abnormal to me, especially the
Excellent.
metaphysis. They appear irregular. I could not appreciate any clavicular fracture. Considering the imaging appearances, my first differential would be of NAI, non-accidental injury, and I would
What
like
else?
to. Sorry,
What
sir.
else?
The next differential would be rickets with the callus with the multiple fractures.
1 second, doctor. Please, my
Yes, sir.
colleagues, don't use the pen. Somebody make this. What else, doctor?
So the second differential would include rickets.
What else?
The third one is osteogenesis imperfecta, but the ribs are normal density.
Okay. What else? Look at this both scapulae, please.
Uh, Sir, they also appear slightly abnormal. Particularly the right one. I
Okay.
think there is some fracture involving the right scapula. The
O-
left is fine, but the right.
Okay. What else? Diffuse, scattered, bilateral, periosteal reaction in an
Yes,
irritable
sir.
crying baby. What else?
Um, Sir, periosteal reactions is seen in the many of the diseases like syphilis and rickets and Caffey's disease, but the mandible and the clavicles are normal, so I'm not thinking of
No,
that.
no. See.
And
You can't see the mandible well here. This is
yes,
not
sir.
an exam for the mandible.
Yes, sir.
So
The clavicles.
don't yes, don't exclude cafe.
Okay, sir.
Okay. Uh,
Okay,
so
sir.
both see يعني both cafe beside rickets beside all. Okay, this is a case of differential diagnosis. What is
Okay, sir.
your next step?
Sir, I would like to do a proper view of the mandible
Excellent.
to
Why?
to exclude Caffey's disease because the
Okay.
mandibular is particularly involved in it. And I would like to
Excellent.
correlate with vitamin D and vitamin C levels
Mhm.
for to exclude syphilis and to exclude the scurvy and the rickets. And I would like to take any history of maternal infection to
Okay,
exclude.
how could you see? Like, okay, you will take a photo or X-ray for a mandible to rule out or rule in cafe. How to rule
Yes,
out or to prove syphilis? There are
sir.
very characteristic signs.
Yes, sir. The Wimberger sign with the metaphyseal.
Excellent, excellent. Okay, so we didn't have any Wimberger sign here. What is Wimberger sign? Here, my colleagues in the metaphysics, there are like يعني corner destruction. Okay.
Yes, sir.
Excellent, doctor. Um, what is the prognosis for of cafe disease?
So I'm not sure.
يعني is this chronic disease, self-limiting, like
No,
this?
no. I think it's self. I think it's self-limiting, but I couldn't remember exactly.
Excellent. Thank you, doctor, so much. Really, I'm so impressed. Really, because it is very difficult and really it need more zoom in. Uh, my colleagues, see,
Thank
you
you.
must zoom as you like. It is allowed for you in Viva. Zoom. By the way, the examiner will be happy if you zoom. Do as you are doing in your usual practice. He won't see the idea of Viva is they putting you under big pressure to see what is inside your mind, to see the usual daily habit. Okay? Zoom is one of the most important. It will help you too much. Second, it will give them very good impression. I think I read 1 year before at the site of FRCR, one big attention from FRCR to us, to the candidate, that most of you didn't Zoom, and this is not good. Okay, my colleague? See here, my colleague, what happened? This rep is not normal. At least there are expansion. Okay, the clavicle, sorry, the both scapula are slightly denser, and here the humerus, there are bilateral periosteal reaction, bilateral periosteal action. So we are dealing with a case of periosteal reaction for differential diagnosis. Our doctor did very well when she enumerate 1, 2, 3, 4, and exclude syphilis because there are no Weinberger sign. I will do X-ray mandible to prove or roll out the Cafe disease. Mandible is very common to be affected in Cafe disease. Very, very common. And then clavicle and then scapula. It was a case of Cafe disease. Thank you, doctor, so much. Next candidate.
Hello.
Hello, doctor. Request control, please.
Excuse me. Sorry, sir. I need to ask a question regarding the previous case. I
Yes.
was worrying about the position of the umbilical arterial catheter, whether it was malpositioned. Uh,
The case, 1 second. I think this.
yeah.
Maybe, but really, it needs zoom. I think maybe the catheter here, maybe.
I have requested remote control. I will like to see
Okay.
it. Uh,
Yeah. I'm not
so this
against you.
one, can you see? So, this one, this line is going up, and this is approaching the
Yeah,
thoracic
there
vertebra.
are a line here up. This is the arterial, but we have two
Yeah.
position for the arterial, by the way. One low and one high. The higher
Yeah.
one, 11, 10, 9, 9, 8, 7. Yes, it is a little bit high because it must be between 7 and 9, a little bit high. And this also I didn't, يعني,
Lower in
I
position
didn't,
umbilical venous catheter.
maybe, but I didn't clearly pick up the tip. Okay. But anyway, in case of any abnormality of the catheter, either the image from the beginning will be very big or obvious, or you can zoom. But because here we are in on Radiopedia, we can't zoom. Thank you, doctor, so much for this very valuable remark. Okay,
Thank you.
this is your case. 1 year
Okay,
male
this is
patient presented with history of high fevers. Go on.
high grade fever. Sorry,
Yes.
Adil.
1 year,
Okay.
1 year, presented with high grade fever.
Okay, this is a lateral radiograph of the neck of a 1-year-old child having fever. And there is showing the cervical vertebra. I can appreciate that there is a thickening of the soft tissues in the prevertebral region.
Yes, excellent.
It is displacing the air passages anteriorly. I'm looking for, I'm also suspecting some right over here, some soft tissue opacification in relation to upper cervical vertebrae. Um, there are also gas lucencies within this prevertebral and large prevertebral soft tissues. My principal diagnosis in this case is prevertebral collection or abscess. I
Excellent.
would like,
Collection
yeah,
or abscess?
yeah, abscess because there are lucencies in it.
And the fever.
So,
The
like,
patient has fever.
yeah, yeah, also, and so early senses are also there. So, as this is emergency, I will urgently inform the findings of the referring physician will
Excellent.
suggest referral to the pediatric ENT referral for urgent drainage and also secure. I will ask for the to secure the airways as it is causing displacement of the air passages. Uh,
Excellent.
so also I would advise follow-up imaging. Thank you.
Before follow up, do you want to do any
I would
type of
like to say,
imaging?
yeah, cross-sectional imaging. I would in the form of MRI of
MRI
the
or
cervical.
CT?
Because as this is infant, so I would not recommend CT scan due to radiation burden. So MRI is the investigation of choice in infants and pediatric age group.
Brilliant. Thank you, doctor, so much.
Thank you, sir.
Doctor, could you tell me what is the maximum normal thickness of this prevertebral soft
So
tissue?
usually in roughly we can estimate it by measuring the total by observing the length of width of the adjacent vertebral body, as
Okay,
this was I think more than twice of the vertebral body. But I think if I
excellent.
would talk about the measurements, I think more than 7 centimeter. I'm not sure. I need to read
Centimeters?
it.
No, 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 no.
Oh,
Centimeter,
Sorry,
much.
Sorry.
Mm
Sorry.
at
Yeah,
C2. At C2 more
yeah,
than
at C2.
6 mm. At C6 more than 22. Okay,
Yeah,
it is
at
it
C2.
is
Okay.
opposite. At C2 6 mm. At C6 22 mm. Okay, thank you
Okay.
so
Okay.
much, doctor. This is
Thank you,
a
sir.
case of patient with fever, remarked prevertebral soft tissue thickening containing gas lucency. It is prevertebral abscess, life-saving until proved otherwise. Upper, upper airway and MRI and the urgent referral for drainage is your next step. So, okay, thank you, doctor, so much.
Thank you, sir.
Okay, next candidate, request control, please.
Assalamualaikum, sir.
Wassalam. Request control.
Yes, sir, I have requested.
Go on.
Okay. This is a CT brain plane of a child, in which the first significant abnormality, I can see that there are multiple calcified nodules noted in subependymal locations of bilateral lateral ventricles. Other than that, I can also see that there are also multiple hypodense areas scattered within the white matter of bilateral cerebral hemispheres. Now going downwards, these regions are again redemonstrated, and I can see that there's also mild hyper intense or thickening of the gyri also noted in the left right frontoparietal region also. These now coming towards the ventricles, the lesions noted in the ventricular region, subependymal location, are not showing any significant lobulated mass.
Yes.
So, keeping in view the radiological findings on this plain CT brain, it is most likely a case of tuberous sclerosis with multiple subependymal calcified nodules and multiple white matter hamartomas. But I
Yes.
will like to see this on post contrast CT or on MRI section to see other complications. And in this particular CT scan, I cannot see any mass at the foramen of Monro, which is causing a significant obstruction or hydrocephalus. And further, I would also like to know about the history of the patient, if there is any history of any facial port wine stains or any history of adenoma sebaceum or any history of seizures associated with this. And also, I
Excellent.
would do the family screening of the patient also to know any history of similar findings in the siblings, and also will counsel the patient for genetic screening and further management accordingly. And
And
also,
for
I
the
would.
abdomen,
Yes, sir. And sir, follow-up would be done as 3 months or 6 monthly neuroimaging, and also abdominal ultrasound to look for any angiomyolipomas in the kidneys. And also, so this is, and in the lungs, patient can have lymphangiomyomatosis also.
thank you, doctor, so much. I will
Thank you, sir.
add only one thing here. You should
Yes,
also
sir.
tell the examiner. I will have a look at foramen of Monroe. There are no obvious masses. Why?
Yes, sir. I have.
Because
Yes,
you,
sir. Subependymal giant cell astrocytoma is associated with
SIGA.
it.
Yeah. Excellent, doctor. This patient presented with convulsion and some skin abnormalities, as you mentioned, CPAM, and mental retardation. Is
Yes, sir.
familial. Thank you.
Thank
The
you.
tumors here, either subependymal here or
Yes,
subcortical, like here.
subcortical. Yes, sir.
Yeah. Sub tuber. Tubers is a hamartomatous disease. Thank you,
Yes,
doctor,
sir.
so much.
Thank you, sir.
Maybe, thank you. Sometimes the tuberous sclerosis may be associated with some renal tumors, but this is not the most common association with RCC. What is the most common syndrome that associated with RCC, doctor?
Um, Sir, I think RCC is associated with the, so it has hemangioblastomas and
Yes, Von.
von von Hippel-Lindau syndrome.
Excellent, doctor. Thank you so much.
Thank you, sir.
Thank you. Next candidate.
Assalamu alaikum, sir.
Assalam, request control, please.
Sorry, sir, I cannot. I am via
Okay.
mobile. I'm outside.
Okay. 5-year-old male patient presented with facial anomalies and mental retardation.
So I've been presented with the CT axial scan, non-contrast images, in which I can see that there's an area of encephalomalacia eliciting CSF signal involving the posterior parasagittal region. Apart from that, there is absence of septum pellucidum as well as monoventricle formation supratentorially. Also, there is an evidence of fused frontal lobes. So if you can scroll down, I would like to see the thalami. The thalami are not fused. However, there is evidence of fusion of the lateral ventricle supratentorially. And inferiorly, I would like to see the posterior fossa structures. So the posterior, there is mild dilatation of the fourth ventricle. Otherwise, the brainstem and the cerebellum appears intact.
What's your
So, sir, looking
differential
at this,
diagnosis?
sir, as the thalami are not fused, my first diagnosis, so it appears like holoprosencephaly, lobar type.
Okay.
But however,
Look again. Okay, you are right, but not lower type. Look here. See, half the brain is separated posteriorly, and the anterior half
it is fused.
completely
Yes, sir.
fused.
Fused. Yes,
So,
sir. Semi-lobar.
excellent. So,
Yes, sir. Semi-lobar.
yes.
Yes,
So,
sir. I would inform the finding to the referring physician and ask, as it is a congenital anomaly, so I will ask for the refer for the genetic testing, and also ask to convey the findings to the parents for the further management of such cases, because they are
thank you,
like
doctor,
cerebral
so much. Thank you so much.
patient.
See, my colleagues, this is a holoprosencephaly. Which type? Look here. Half the brain, anterior half, is fused. See? Fused. This is the white matter. See, this is the most easier sign to pick up. White matter, white matter, white matter, white matter. Okay? So there are fusion. Even the anterior part here of this structure, okay, is fused. But posteriorly, there are separation. So this half holoprosencephaly is semi-lobar holoprosencephaly. And see here, this is still monoventricle, still, still monoventricle. This is by way not as encephalomalacia. This is a cystic lesion or structure. Okay, my colleagues, the posterior fossa is completely normal. Thank you, doctor, so much. The most important sign in holoprosencephaly is absence of septum pellucidum. Very important. Sometimes in the septo-optic dysplasia, you just see find absence of septum pellucidum. And if you go down, you will find that both optic nerve are completely small. Here also both optic nerve, by the way, is so small also. Anyway, also here, see, the phalanx is not at all present posterior. Thank you so much, doctor. Next candidate. Next candidate.
Hello, doctor. Yes, please.
Welcome. 5-year-old male patient. Fall down.
Okay. I request control or
Yes, please.
absolutely okay. Okay. So, can I know the history of the patient? Sorry.
Patient is young age, post-trauma. You can go through the 3 view of the X-ray.
Okay. Okay. So this is lateral cervical X-ray of a child. I, so I can see that vertebral alignment is preserved apart from mild C2, C3, um, anterior subluxation, which is, I think it's accepted in the pediatric age.
Excellent. This is acceptable pseudo-subluxation. Excellent.
Pseudo-subluxation.
Yes.
I'm trying to look at the atlantoaxial space, which is, I think, in my routine practice, I will measure it, but I think it's a bit prominent. But I will check the other views for any
Okay.
to confirm if
Go
there's any
through.
injury. Okay. Um,
1 second.
okay,
1
it's
second.
an oblique.
Look here better. 1 second.
Okay. Oh, yeah, this is better. Yeah. Mm. I think the anterior mass there's non-fusion of the anterior
Okay, where?
arch of
Okay,
atlas, but
where?
here,
Okay.
okay.
See,
I don't think that this
this
traumatic.
is post-trauma. See, this is
Yeah.
post-trauma.
So I'm trying to comment on the bone integrity. So I can't see the lateral limits of the lateral mass of atlas, but um, mm, um, I can't see any abnormality in this image. And the mandibles, there's no mandibular fractures. No fractures seen in C2. I think it's symmetrical atlantoaxial distance, lateral atlantoaxial distance.
Okay.
So I would like to check the rest of the images.
What would you do next?
If there's a high clinical suspicion of injury, of cervical injury, I would like to do a CT.
Okay.
Can't see abnormality in the soft tissues or the bone.
Leave the mouse. Leave the mouse 1 second.
Okay.
Go on.
Okay, this is the cervical spine. This is axial sections of bone window of cervical spine, CT. I'm trying to scroll. Okay. So I will take a moment to scroll through the whole set of images.
Stop
Okay,
here.
okay.
Stop here.
So there is
So what happened?
yeah, there is a
What
comminuted
happened?
fracture of the left lateral mass of C1.
Okay. What else?
And I think there is also malalignment of the cervical um, craniocervical junction. As I go up, there is slight malalignment. I would like to check it in the coronal images.
Okay.
Okay. So there is widening. Yeah, there is. Okay. I'm trying to check hypoglossal canal. I think it's normal on
Doctor,
both sides.
from the X-ray, you have a
Okay.
problem at C1. So when you get the CT, concentrate on it first. Okay, what happened here? Leave the mouse. Leave. I'm scrolling.
Okay. So there is a
What
comminuted
happened?
fracture we've
See,
seen.
see.
And
Yeah.
yes, the posterior arch, yes. Here I can see that it's there is a fracture in the lateral mass and posterior arch, and
Okay.
this
What
is
is the name of this
an
fracture?
unstable fracture.
Okay. What is the name of this double fracture in C1?
I can't recall.
Do you remember?
Jefferson fracture.
Excellent. What
Yeah.
will you do next?
So I will urgently call the referring physician, and I will request an MRI spine, urgent MRI spine to assess any spinal injury. And I will
Okay.
advise neurosurgical advice, urgent neurosurgical
Could you
advice.
tell me, or could you know the mechanism of injury here?
I think axial loading.
Excellent. What is the most common scenario? يعني how this, how this child, what he was doing, then
Maybe,
he.
yeah,
Mm.
maybe swimming,
Oh, excellent.
diving, and
Excellent. Thank you. Thank you.
for my thank you.
Thank you so much, doctor. See here, my
Thank you.
colleagues, this lucent line, at least this is the examiner. If you didn't want to tell this is a fracture, tell him there are a lucent line in the expected location of C1 arch. I will do CT. Okay. Then you will do CT. Please concentrate in axial. The cache here in axial. And you told something about C1, concentrate in C1 and compare. Here is intact. So this is a fracture, number one. Number two, go down, 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 down. What is the defect here? Okay. To diagnose Jefferson fracture, it must be a double fracture. One in the posterior arch and one in the anterior arch. Okay, my colleague. This is a Jefferson fracture need an urgent referral. Thank you, doctor, so much.